So we'll go ahead and get started. Thanks for joining us today for the Epilepsy podcast. And today we're meeting with Dr. Shabbar Danish, who's the chairman of neurosurgery at Jersey Shore University Medical Center. Dr. Danish did his residency training at University of Pennsylvania hospitals, and he was a faculty member at Robert Wood Johnson University Hospital in New Brunswick for several years. He's really one of the nation's leading neurosurgeons when it comes to the application of LIT, or laser interstitial therapy, for intracranial applications. And we're excited to have him here today to talk a little bit about LIT, specifically as it pertains to the treatment of patients with drug-resistant epilepsy. So thanks, Dr. Danish, for joining us today.
Thank you. Thanks a lot for having me. I appreciate it. So looking forward to the discussion.
Great. Rohit, you want to go ahead and get started with the first sort of question?
Sure. Thank you, Dr. Tomic. Dr. Danish, one of the recent developments to affect stereotactic tissue ablation in epilepsy surgery is laser interstitial thermal therapy, also known as LIT. What is the basic idea behind how LIT works, and why can it be effective in treating focal epilepsy?
So the concept of lasers in surgery in general is not new. One of the gaps in its application in neurosurgery was two things. One is the inability to predict the ablation, and the other is the inability to follow it in real time. So those are the things that really changed in the 1990s, and then in the 2000s you had two FDA approved systems come to market. The big change over prior ablative techniques is that you have real-time image guidance via MR, and that's what allows you to follow the distribution of heat in your target in a real-time fashion, and then make decisions based on that. In terms of part two of your question, why it can be effective in treating focal epilepsies, creating ablations and disconnections in the brain is not a new concept. So anywhere where you can create a disconnection in the brain is somewhere where laser therapy can potentially give you a similar outcome through a minimally invasive approach. Now whether that actually happens is a more complicated, issue at hand.
So, Dr. Danish, you alluded to this technology coming up in the 1990s. Before this, people were using RF electrodes, radio frequency ablation. Do you have any experience with this yourself? And can you talk about, you alluded to it a little bit in that first answer, but can you talk about why LIT is really an improvement over RF ablation?
I think there's, two reasons. One, again, as discussed, it's the idea that you have real-time image guidance, which you cannot have with RF. That's one. And I think ultimately that is what has driven this sort of technology across the finish line and allowed it really to sort of stick around and grow. The other is that you have some control over the ablation, because you can control some parameters and you're watching it. So you can actually have some sense of control over the size and the volume of the ablation, which you do not have with RF.
Right. So for RF, you're going to get a certain ablation, and
you're going to set a temperature and set a time, hit go, and then you're done. Good.
And can you talk a little bit about how LIT has compared to open surgery, sort of traditional means of treating epilepsy, specifically for maybe you can talk about mesial temporal sclerosis or hippocampal sclerosis,
sure,
and some of the other types of focal epilepsies, but maybe start with that one.
Yeah, well, I think that while it's natural to feel that laser therapy or any minimally invasive approach is a competitor, in sort of a head-to-head match with open surgery, I don't think that's necessarily always the case. Now, if you have, as you said, like pure mesial temporal sclerosis, yes, in that scenario, I think you have, this can be a competitive approach. It's a minimally invasive approach that can achieve a similar outcome in terms of what you do during open surgery, depending on how you approach the open surgery. even in the world of open temporal lobe surgery, as we all know, there are a lot of different options. There are nuances to how these operations are approached. Depending on that, you're doing something a little bit differently during surgery. So, for example, there are folks who will do in MTS or mesial temporal sclerosis will still do a standard amygdalohippocampeectomy with a neocortical resection of the temporal lobe. And in that scenario, if you look statistically across the board, of course, if you take all comers, they're going to have improved seizure outcomes, because in many of these MTS patients, as you know, it's an epilepsy network. And the longer it goes, the more complicated that network goes. And there are going to be instances where part of the seizure onset is in the neocortex, along with the medial temporal lobe. Now, if it's purely, if it's MTS with an onset that's clearly in the hippocampus and not anywhere else, then I think laser therapy is going to give you a very similar outcome if done, if done well, right? It's because it's minimally invasive. That operation also can have, instances and when it's not done right or not done well. And I think the complication profile just changes. Minimally invasive things always feel safer because it's a smaller entry point. And you're not really, you don't see a big incision or a big craniotomy, but I think that the complication profile just changes. That being said, with the laser approaches, it's, you take a 3-day hospital stay and it's always overnight.
Yeah,
Doctor.
No,
Sorry.
those are all good points, and I think specifically in in children, we do think a little bit more about the complexity of the epilepsy network, and in particular, they seem to have a higher chance of dual pathology, even in cases of mesial temporal sclerosis, where you have to think about neocortical involvement. But those are all very good points. Rohit, you want to move to the question about risk?
Sure. Yeah, Dr. Danish, you kind of touched on this, and you were talking about how no treatment, even if it's minimally invasive, is free of complications. Could you talk a little bit more about the complications you encountered with LIT, and also how LIT might present challenges if open surgery is pursued subsequently to it?
Well, the complication profile for LIT is going to be similar to other stereotactic procedures in which you're putting probes or wires in the brain and going some length through the brain. You have divide these into insertional complications and treatment related or ablation complications. So insertional complications are generally hemorrhage or the fact that the laser does not go in the right place. And both those things are rare, but they can happen. And in the ablation complications, you can get ablation-related hemorrhages. If your laser is not in the right place and it goes unrecognized, and then you turn the laser on and ablate, then you will create create unintended complications based on the neural structures around you. So in the world of, say, temporal lobe epilepsy, just for example, if you fail to recognize that you have a very narrow ambient cistern or CSF cleft between the brainstem and the amygdala, you will get cranial nerve injuries, which you do not get with open surgery. The complication profile is just different. You still have to be extremely careful as with any other operation. Now, encountering, going through open surgery after LIT, I think depends on what exactly you're alluding to in terms of the question. The post-ablative tissue, looks like a scar, or it's chronically just necrosed, and it comes out like any other tissue you would go in. Now, why you would go into open surgery after laser therapy for epilepsy is also a more complicated question, but it can be done.
What kind of conversation, Shabbar, do you have with your own patients when you're offering them LIT, specifically for MTS? Because I always tell them that there is a possibility that if they recur, then open surgery is still an option. Do you kind of talk
I think
with them a little
epilepsy
bit?
patients come from different backgrounds. A lot of it depends on their own perception of their disease, their disability, what they're trying to achieve, what they have been communicated to, through their own physician network and their neurologist over the course of their disease before they even get to us as surgeons. So I think all of these things play a role in that. Now, if laser therapy is an option for patients, I will always offer it first. It's minimally invasive. And I tell patients that, there's a good chance that we achieve the outcome they're looking for, and we can avoid all of the issues with open surgery if that occurs. In fact, laser therapy is oftentimes, or most times, less invasive than a phase 2 monitoring procedure with intracranial EEG. Right? If you're going to survey patients with temporal lobe epilepsy, it's going to be more invasive than the laser procedure for sure. So I think that allows patients to buy into it. I don't refer to it as a surgery, even though it is, just because there's a lot of psychological, stigma associated with just that term for epilepsy patients. It just ends up being another procedure for them. And if they don't achieve the outcome we're looking for, then, we have that chat down the line.
Understood. That's interesting that you don't refer to it as a surgery. So refer to it as a procedure for your epilepsy.
Yeah, because again, the other, broadly, laser therapy is used in the world of neuro-oncology, but in that world, those patients, they don't react the same way to that word operation or surgery. They, they are very, that doesn't incite the same level of fear as it does in the epilepsy patient.
Good point. Right.
Dr. Danish, so LIT has become the treatment of choice at many centers for a range of pathologies, for example, for dominant-sided MPS, periventricular nodular heterotopia, hypothalamic hamartoma. Why is this technology especially appropriate for these type of lesions?
Well, I think surgery in general, whether it's laser therapy or otherwise, in the world of epilepsy is much more successful broadly in the world of lesional epilepsy syndromes. If you divide epilepsy broadly by lesional epilepsy syndromes versus non-lesional epilepsy syndromes. And I'm talking one in the adult world mostly. The pediatric world is a little bit different, where in the peds world, as Dr. Tomic will attest to, you can cure a lot of epilepsy by disconnecting certain networks in the brain. Now, if you need to achieve a disconnection, you can certainly do it by laser therapy. But in the adult world, you're not doing the same types of operations, not same types of pathologies. So I think anytime you have some type of lesion or abnormality that is the focus of the epilepsy, whether it's a hamartoma or it's a tuberous sclerosis nodule or it's a PVNH or an MTS, that's where surgery, ablation, removal, disconnection is going to be fairly successful. And you're trying to achieve that by and minimize collateral damage, right? So in the world of periventricular nodular heterotopia, these are generally deep, and you have to traverse some segment of the brain to get to them, and so these are surgically extremely challenging, especially when they are located, they're always located around the ventricle, hence their name. So you're traveling through a lot of the brain in order to get there. So I think in those scenarios, something like laser therapy has been a real home run because you can avoid the collateral damage of the trajectory.
Now, Dr. Danish, you use LIT a lot in your own practice for brain tumors. Can you talk about the typical patient that you would treat, or is there a typical patient? What sorts of brain tumors are you thinking about the use of LIT?
Well, I think in the world of neuro-oncology, if we just broadly divide this between primary tumors and secondary tumors, meaning, metastases, I think that we've seen a lot more utility, interest, and changes in the clinical algorithms across centers in the world of secondary tumors. In the world of primary tumors, just say in the adult world, high-grade gliomas, I think we have, come to, accept, long before laser therapy has been around, that focal treatments are not going to be the ultimate solution for that disease process. It's part of it in terms of managing it and trying to keep it in control, but not sort of, does not present finality in treatment in that disease. Whereas in the secondary cancers, such as metastases or recurrent metastases, where LIT has been very successful, those are focal problems. So using LIT as a focal therapy for focal problem has been immensely successful. There are still areas of discussion / controversy in that world, especially when you have a brain metastasis that ultimately is, gets surgery and radiation, and then it comes back in some form or fashion. There's still a lot of discussion in a lot of centers as to what is that entity that comes back. Is it a radiation vasculitis? Is it radiation necrosis? Is it a recurrent tumor? Is it a mix? And this has actually been a source of my own personal scholarly and research interest over the last 10 years, as you try to figure out how to make that problem solving easier for the patient and the practitioners.
Dr. Danish, could you talk about the post-operative care for these patients? This could include the imaging, use of medication like steroids, observation in the PICU, length of stay, things like that.
Yeah, I think some of it depends on what you're actually treating, but broadly speaking, in general, these patients require an overnight stay. That's it. I think using a week or two of steroids post laser therapy is something that we routinely do, but not necessary in many instances. A lot of it depends on the patient's symptoms, pre-op and post-op, the size of the target, where the target is. But I think in terms of imaging, I think that's also varied. I think routinely most centers will do an immediate post procedure image, or either immediately or 24 hours, and that serves as a baseline. And then how often you do it afterwards really depends on the pathology you're treating. But the length of stay in most institutions is probably somewhere between 1 and 2 days, with most people just staying overnight.
So I'll go ahead and finish up with this last question, and thanks for again taking time to talk to us about this. I do think LIT's an exciting therapy for epilepsy. Like you said, it's mostly a focal treatment for a focal disease. Increasingly in the peds world, we are now using it for things like corpus callosotomy. So indeed, patients with generalized epilepsy can also sometimes be candidates for laser ablation therapy. Tell us your thoughts about the future of LIT. Is there work being done right now to improve the laser probes in any way, to increase the accuracy of the tissue monitoring the temperature of the tissue during ablation? What are sort of the future challenges for LIT?
I think that so there are 2 FDA-approved systems, and I'd say that one of the FDA-approved systems, for example, the one made by Medtronic, has spent the last 2-3 years really doing an overhaul on the software side of things. We've seen a lot of changes in the software. I think that users are going to want this idea that you have an infinite amount of control around the boundary of what is ablated, and that is not achievable yet. And I'm actually not sure that it's quite necessary, but it will give users a sense of control. I think that my hope is that you have more flexibility with the power that the lasers are able to deliver, because at the moment we don't have a good sense of, even after 10,000 procedures around the world, you don't have a sense of, when you get into a target, how it's going to respond to the thermal energy. And then if you are you have very few parameters that you can change in order to achieve your desired outcome. So I think those things, my hope is that there's some investment. But if we look at where how the field is moving, we have tools for non-invasive ablation using ultrasound. And I think that as those tools improve and the ability to ablate targets using that technology changes, I think how we look at implantable laser devices is also going to change.
That's a great point. Dr. Danish, thank you again so much for your time.
All right, guys, thank you very much. Okay, take care.
Thank you.
Thank you for listening to the Epilepsy podcast. The video content and audio content is not intended to be a substitute for professional medical advice. The views and opinions represented here are merely the views and opinions of our expert guests. Thank you.